Thank you very much. Good morning. I love that call and response. Dean Amman, thank you so much for that introduction. I want to take a moment to thank Dean Harris and the Office of Diversity and Inclusion for inviting me here today. And special thank you to Claire Grimble. She's the one that made this entire event possible. So Claire, thank you very much. And thank you to all of you for being here, for taking time out of your very busy schedules to take part in this conversation and to be present. It means a lot. So thank you very much. When we were first workshopping an idea for the title of this talk, I wanted to go with the title of an essay that I've been working on for the last year or so called A Healthcare Trainee's Guide to Changing the World. And eventually, we settled on a much more subtle and appropriate title for the talk. But I maintain that my goal here today is not to share with you something that you haven't seen or heard before, but rather to share with you a paradigm shift that I think is going to become increasingly important, not just for us in healthcare, but for agents of change working in systems everywhere. And before I begin, got to make sure this works. One moment. Beautiful. Before I begin, thank you so much, David. I want to take a moment to thank a number of individuals who have been instrumental to my growth and all of the work that's going to be talked about today, and all of the institutions that I've had the privilege of calling home for the last couple of years. And without these people, none of this would have been possible, and I'm deeply, deeply grateful to each of them. So, like I said, nothing that I'm going to be sharing today is radically new. Individual people and groups of people have been working as agents of change in almost every movement known in human history. And we saw examples of this throughout the 20th century as people were fighting for the right to free speech, fighting against apartheid, and fighting for equity and for justice in this country. And central to Dr. King's own legacy was this idea that individual people or groups of people could come together and start grassroots movements that would eventually grow to become some of the most powerful social movements in human history. And there's a quote from Dr. King that I love. He says, "Make a career of humanity. Commit yourself to the noble struggle for equal rights. You will make a greater person of yourself, a greater nation of your country, and a finer world to live in." And I would argue this is exactly what we're trying to do each and every day on this campus. We're trying to create a safer, healthier, finer world for our patients and for our community. And we've been doing that in this city, in this decade, still fighting for equity, still fighting for justice, fighting for reproductive justice, and fighting against genocide, and fighting for the right to a clean, healthy, safe planet, not just for us, but for our children. And central to all of these movements and all of these important social progresses that we've seen in the last couple centuries is one simple idea: that individual people have the capacity to change their systems. So the game plan for today, when I was first invited to give this talk, I had a conversation with Dean Harris that morning. And I went home and I called my sister. My sister is here with us today. My sister's my best friend. I called her and I said, "Annika, I'm super excited. I have the chance to give this talk and it's scheduled to be like 90 minutes long." And she cuts me off. She says, "Beya." Beya in our language means older brother. "Beya, I love you, but no one needs to or wants to listen to me talk for 90 minutes straight." And I said, "Fair." So the goal for today is not for me to stand up here and yap for an hour and a half, but rather to set the stage for a conversation that you'll be able to have amongst your groups and with yourselves. And then we'll come back together, walk through what we've dubbed are the 7 steps for change. And then you'll have the chance to work through these ideas again with your groups. We'll share out around the room, and then we'll close out towards the end. And so with that, I want to take a moment to share a story that takes us back to my first year of medical school as a trainee in this healthcare system at BU. And for some of you that are familiar, in our first and second year of medical school, we go through a clinical skills development course that is affectionately known as doctoring. And in this course, we learn all the basics. We learn how to actually use a stethoscope, unlike the people on Grey's Anatomy. We learn how to properly conduct a physical exam and do interviews with real patients. And my doctoring advisor, Dr. Ferenz, is here with us as well. And she would tell you that I was notorious for always forgetting to ask patients whether or not they had drug allergies. And eventually, by the end of first year, I got it. But part of the reason for this is that as first years, we're paired with a fourth-year medical student preceptor, and we practice our interview skills with real patients at BMC. And so my fourth-year preceptor, DJ, had a patient that he had asked beforehand if I could go and practice my skills with. And we went up to BMC, and just before walking in the room, DJ gave me a heads up. He said, "Neil Singh, just so you know, this patient's incarcerated. There might be some other folks in the room with her. Are you okay conducting this interview?" And I said, "Yeah, of course." And we walk in the room, and there's two armed guards sitting at this patient's bedside. And I pull up a chair next to her, and we start talking. She's this little old lady, barely 100 pounds. She has a terminal diagnosis. And every minute or so, as she was sitting there, she would try to sit herself up in her bed. And you could hear the sound of the shackle that was around her ankle playing against the hospital bed, and she'd slide right back down. And this happened 10 or 12 times while I was in there. And I walked out of the room, and I turned to DJ, and I was like, "Dude, this doesn't make sense. This patient's not going anywhere. She could barely move any one of her limbs. There's no need for her to be shackled. We still do this? This doesn't make sense." And DJ says to me, "There's a lot of things within the American healthcare system that don't make sense." And I think a lot of us in this room would agree with this sentiment. So a couple weeks later, I went to go see two of my old professors, Dr. Sandra Crosby and Professor George Annis. They teach a health and human rights course at the public health school that I actually took the year before as an undergrad at BU. And I was talking to Dr. Crosby about what med school is like. She reminded me of the importance of asking patients about drug allergies. And I told her the story about the patient that I saw with DJ. And Dr. Crosby shared a story with me that eventually came out from one of our residents about a patient that was sedated and intubated in one of our ICUs, went into cardiac arrest, and died in shackles. And I asked Dr. Crosby the same question that I asked DJ. We still do this. Now, the title of the piece that Dr. Lescure wrote in the Washington Post was "No Patient Should Have to Die in Shackles." And when I asked Dr. Crosby that question, she says to me, "Yes, but you can do something about it." And I was like, "But Dr. Crosby, I'm just a medical student." And even though I'm guilty of using it myself, I hate this phrase. I hate this phrase for two reasons. One, it takes a lot to be able to say that we made it to our first day as a freshman on a college campus in this country, let alone to be able to say that you became a nurse, a resident, a med student, a physician. You're not just any one of these things. But I also hate this phrase because it makes it seem that a single individual operating within a system doesn't have the capacity to change that system. And so the paradigm shift that I'm hoping becomes more widely accepted in healthcare is not that you're just any one of these things. You are a human who operates within a system. You're a human who operates within a system. Now, those familiar with systems framing or systems thinking will know some of these concepts, but at its core, a system is nothing more than the sum of its parts and how those things interact. And people are at the center of these systems, and the system can be anything as large as Boston Medical Center or a smaller system like a private practice family medicine clinic in rural Massachusetts. Systems have outcomes, and those outcomes will also feed back on the system. And simply because people are a part of these systems, people have a capacity to change both the system and its outcomes. And these outcomes can be anything that we care about, from the average life expectancy in the United States to the maternal mortality in Massachusetts as compared to Mississippi, the number of people dying every year from firearm violence in this country, or the excess patients we see in our emergency rooms because of climate change in the Boston summer. Those are all outcomes that we care about. And outcomes can be good or bad. And if we follow Dr. King's line of thinking, our objective to create a finer world is to maximize the good and minimize the bad. The other core tenet of systems thinking is that as time goes on, systems are going to change. Boston Medical Center is ever so slightly different today than it was yesterday, And it will be different tomorrow than it is today, simply because as time goes on, systems will change. So when someone asks me the question, can I change my system? I would argue that you're going to, simply because you're a part of that system. The more important thing to figure out is what you want to change about that system and how you want to change it. And both of those things are up to you. Someone might say, well, why should I care? I just want to get into med school, get my degree, and get out. I don't want to rock the boat. I don't want to make any noise. I don't want to change anything. And fair, making it through med school is hard enough, as many of us know. But when we look at the systems that we have today, we hold the people who designed these systems 20 years ago, 50 years ago, we hold them accountable for how good or bad our systems are today. 20 years into the future, 50 years into the future, we are the ones who are going to be held responsible for these systems. We're the ones who are going to be held accountable for their outcomes. So I would argue we as trainees should care even more about how good our systems are because they're our systems to inherit. So I want to take a moment to pause there. On the sheets that are on the tables in front of you, there's a spot for you to reflect on a couple of questions about the systems you're in and the roles that you have. Feel free to take a couple of minutes, introduce yourselves to your tables if you haven't already, and we'll come back together in about 10 minutes. All right, folks, I'm going to try to bring us back here if we can. I hope everyone got the chance to at least know the 6 or 7 people sitting around you. And we will have the chance to share out in the room as well after this next set of slides. The game plan for the rest of the afternoon is now to walk through the 7 steps for creating change within a system. And I'm going to be the first to say, if you were to Google, what are the steps for creating change, you will come up with about 100 different iterations of these steps that will vary a little bit based on the industry they come from and who wrote them. The reason that we chose to lay them out this way is, one, I think is a little more helpful for those looking at this from a healthcare system perspective. And second, as I go through each of the steps in theory, I will walk through the shackling project, the initiative that we worked on for the last couple of years here at BMC, as a sort of case study of what these look like in real life. And so with that, the first step of the 7 is to define the problem. And I know this sounds radically simple, but when you're defining a problem, you want to be precise and figure out what exactly am I trying to change. And so for us, when we first figured out, there's patients who are quite literally dying in shackles at our hospital, we weren't going to overhaul the entire correction system in the span of our first year of medical school, but we knew that our objective from day one was that no patient should die in shackles. And so in the context of our system, we figured out what specific thing we wanted to change. And there's a cliche quote from Charles Kettering that I'm sure many of you have heard. A problem well stated is a problem half solved. And this is true because once you yourself have clarity on what it is you're trying to fix, you'll have a much easier time convincing others that it's something that's worth fixing. And then you move into step 2, which is examining the issue. And what I mean by this is you want to be able to answer 2 questions. Why does the issue exist to begin with? And why has the issue persisted? In our case, the issue of shackling patients exists because we almost always defer to corrections on how patients are supposed to be treated when they come from corrections facilities. And so this is how things have always been done. It was an entrenched practice in our healthcare system. The issue persisted because oftentimes people thought, we can't change this. We have no say about the matter. And as we were doing research about this, we found out that up until the last decade in this country, we used to shackle pregnant people while they were giving birth. And so through this, we figured out what were the successes of some other initiatives that people were working on. What were some of the barriers they faced, and what were some of the strategies that they took to solve a similar problem? There's a quote that I'm sure many of you are familiar with from former Vice President Harris about coconut trees. There's a lesser known version of this quote that also applies to systems. Our systems didn't fall out of coconut trees. And so understanding the context behind those systems and understanding what specific approaches might be necessary is helpful before you start to do anything at all. And then step 3 is assembling a team. And everyone on your team is going to have a different role. And I'll also be the first to say none of these steps are perfectly linear, but we'll get into that in a little bit. Some folks on your team are going to be your collaborators. These are the people that you work with day in and day out on the project. And for me, this was myself, Judy, and Nisha. The 3 of us were the med student trio. And we worked on the project with dozens of other people who helped us figure out how we could actually bring some kind of change to the matter. I mentioned the 2 of them earlier, but Dr. Sandra Crosby and Professor George Annis were our primary mentors on the project. And without them, none of this would have been possible. And we had the privilege of good mentorship in them and in dozens of other people who stepped up and helped us lead this initiative forward. And then some folks are going to be advisors, people you ask a question to every now and again, maybe not as involved, but still just as important, because some of those advisors will have stories and insights that will help you move in the right direction. Teams take all different shapes and sizes, but I'm the first to say that when a team functions beautifully, it is indistinguishable from magic. And then we move on to step 4, which is stakeholder engagement. And I know this sounds like a phrase that came out of McKinsey or Deloitte. What this really means is bringing everyone to the table. And so for us in healthcare, our primary stakeholders most often are our patients. It's their stories, it's their lived experiences, it's their concerns that we want to make sure we bring to the table. Other times it's our colleagues. And for us in our initiative, it was our nursing colleagues that we wanted to make sure we listened to. And it was their insights that were most valuable. And actually 2 of our nursing leaders at BMC, Chief Nursing Officer Nancy Gayden and our MICU Nursing Director Avi Rek, actually became key collaborators in helping us champion an initiative forward. And when I say bring everyone to the table, I also mean people you might disagree with. And I'll never forget the first patient that was unshackled because of the policy we eventually implemented. We went to go see the patient. Avi wrote us an email that morning. And I remember peeking through the window. The patient was sedated and intubated, but unshackled. And we start talking to the guard who was accompanying this patient who was sitting outside the room. And this guy's getting weirdly excited. He's like, oh my gosh, this initiative is so great. And he says to us, and I quote, "You guys are finally treating these patients with some dignity." And I was like, of all the people I was expecting to hear that phrase from, the last person would have been someone who works in a corrections facility. So sometimes you'll be pleasantly surprised that people who might philosophically disagree with you actually support what you're trying to do. I'd also be a fool if I didn't acknowledge that yesterday in this country, we inaugurated a president that a lot of us might philosophically disagree with. Having said that, there is no path forward for the American healthcare system that doesn't include all of us. And it is our responsibility as both leaders and as agents of change to find a way to build that common ground so that we can move forward together. And then you move into step 5, which is translating awareness into action. And sometimes these 2 words kind of get clumped together in like a umbrella term of advocacy, but they're 2 separate things. Awareness is helping people understand why the system needs to change. And so for us, we actually wrote a petition in a very noisy, chaotic way to Boston Medical Center. And we wrote down all of the human rights reasons, all of the medical reasons, all of the ethical reasons that patients should not be shackled. And that petition actually became our most valuable educational tool in getting people to understand what this problem is all about. But we didn't stop at awareness. We translated that awareness into action. And that's how you want the system to change. And so over the course of a year, we worked with the leadership from Boston Medical Center and actually implemented a new policy at BMC that allows patients, whether they're sedated, intubated, paraplegic, quadriplegic, terminally ill, it gives us a clearer path to advocate for their shackles to be removed simply because it's the right thing to do. And then you move into step 6, which is implementation. And I wish that I could say I knew this when we first got the policy passed about 2 years ago, but now, 2 years later, I have less hair on my head, many more gray hairs in my beard, and I can tell you the policy change was great, but it was only step 2 or 3 out of about 100 steps we were going to have to take to change that policy and turn it into practice. And that's because we're still on step 6. So you implement a change, and then you figure out, is it working? Is it not? What are some of the unintended consequences because of the change you implemented, and what could you do better? And you go through this process over and over and over. Some of you are probably familiar with this as quality improvement or the PDSA cycle. At the core of it, all this really means is figure out how you can do even better. And the final step is step 7, sustaining the change and sharing the change. And what I mean by this is sustaining the change is important because we as individuals might not remain in the same system forever. So if you implemented a change, that's great, but it has to stay there even once you leave that system. The reason that entrenched practices are called entrenched practices is because things have been done again and again and again the same way until someone comes to change them. So you have to make sure that whatever change you're implementing, you do again and again until it becomes a part of the institution's memory. And sharing the change means whatever progress you've made, don't let it stop at the walls of your own hospital. We've written papers, gone to conferences, and now there's other folks in other states bringing similar changes to their healthcare systems. And my hope is that they actually do it even better than we do so we can learn from them. And that is how you keep the change alive. So I want to take another moment to pause there for a bit of a longer break. Also on the sheets in front of you, there's some space to reflect on these ideas about how you might bring about a change to your system. I'm not expecting everyone to have all the answers in 20 minutes, but we'll come back together in about 20 minutes. Feel free to work on your own, work with your groups, and we'll have a chance to share out as well. Thank you to those of you that shared, and thank you all for engaging with that. I alluded to this earlier. I presented these steps as if they're this perfectly linear process, which they are in theory. This is what they look like in reality, and will much more closely resemble a bowl of spaghetti than they do a line, because progress is not linear. Change is also not linear. And so from the get-go, we were very ready to understand that we were going to have some setbacks. We had to figure things out. That's all part of the process, but something that's important for me to stand up here and acknowledge. I also want to acknowledge that change, especially if you're a trainee within a healthcare system, is hard. And there's some things within systems that make it especially harder for change to happen. And one of those is the lack of time. I would argue our curriculum as med students, we had more time dedicated towards advocacy, but that's not true everywhere. And we spent countless hours outside of our designated time as med students working on this, as does everyone trying to change something. Having enough time to do this is often one of the biggest barriers that people will face. And sometimes the institution is the barrier. I would actually argue most institutions are very resistant to change. And I can't guarantee that if we did the same thing that we tried here at BMC at another healthcare system, we would have had the same results. You're also going to face a lot of criticism. And some of it is constructive, some of it is definitely not. And people had all kinds of things to say to us, that we were crazy, that no one was ever going to go for any of this, that we were just making noise for no reason. Being able to pierce through that criticism, especially the non-constructive criticism, is hard, even if you know that what you're doing is important. And some people just don't have the resources. Some institutions don't have the resources. We have the privilege of having the mentors we do here, but that's not the case everywhere. The funding, the time, the effort that's needed for some of these initiatives is not present at every institution. Institutions need to actively make those resources available to their trainees if they want them to be agents of change. I'm not going to belabor the point of burnout. I think we all know what that is, but I do want to take a moment to acknowledge the notion of fear. Standing up for something and speaking out against something, even if you know it's the right thing to do, is scary. And there was a time not too long after we launched our petition that we were worried that Dean Antman would call us into her office and say, "What the heck are you guys doing? You're making a lot of noise and you're making us look bad." Having said that, we had the right people standing beside us, and we had a lot of great people standing behind us, and we knew that what we were doing was important. And we were able to keep moving forward. But it was still scary. And change is hard. We all know this. Change is also inevitable. Things are either going to get way better or way worse, and we are the individuals who have the power to drive that change in the direction that we're proud of. But the change itself is inevitable. Change is also necessary. I don't think any of us would look at the American healthcare system and say, we've done it, we've figured it out, our patients are all healthy, our outcomes are excellent, our systems are perfect. No. Change is necessary. having said that, and as easy as it is nowadays to look at our phones and see how bad the world has gotten, we have made a lot of progress. There's a lot more to be done, but we have made a lot of progress. And there are countless examples through Dr. King's legacy and all of the work that's come before and after that shows us that change is powerful. Now, some of you are fans of The Office, and you'll appreciate the reference on the next slide. We were at a dinner for the Center for Climate and Health, and one of my mentors, Greg Wallenius, he's the director for the Center for Climate and Health. He gave a speech, and he quoted John F. Kennedy. And in this quote, Kennedy says, "We do things not because they are easy, but because they are hard." Does anyone know what the context is of what Kennedy was talking about from the speech? Going to the moon, exactly, yes. This is from Kennedy's speech about going to the moon. And in this speech, Kennedy says, "We do things not because they are easy, but because they are hard. Because that challenge is one that we are willing to accept." And so my question for all of you is, what challenge are you willing to accept? And what change do you want to see within your systems? Some of you have heard me say this before, and I do believe it's true. The greatest trick that the devil ever pulled was convincing us that we can't change the world. And if you leave this room with nothing else today, I hope that you know that you can and that you will, one way or another. And as we begin to change our systems to do better and to be better, we will come remarkably closer to a world where all people can truly be well. Thank you all very much.